Hello, so today we are going to do part one of a 2 video series on EKGs. So today we're going to cover basic anatomy and physiology of the conduction cycle and the cardiac cycle. We're going to talk about wave identification, analyzing rhythms, and rhythm interpretation, okay? And part two, I'll go on to talk about exactly clinically how the patients look and how we will manage and treat the patients. So let's get started with part one. So the first thing I think we need to do is have a good understanding of what we mean by the cardiac cycle. So with the cardiac cycle, you have your contracting and you have your relaxing. Okay. And so in order for us to have this happen, we have to have some kind of electrical impulse, some type of electrical stimulus to make this mechanical response happen. So the first thing I want you to take into mind is that all of the cardiac cells have the ability to initiate electrical impulses, okay? Although we all know the pacemaker, who's the chief of the house, he usually sets off the electrical response, okay? But all of the cells in the heart are able to do this. So once we have this electrical stimulus shoot out, we actually have what we call the cells depolarizing. And the mechanical response to depolarization is going to be contraction. And we call that systole. And when those cardiac cells actually recover from the depolarization, we call that repolarization. And for us, that's diastole. That's the mechanical response. And that is the relaxing and the filling of the blood in the chambers. So let's put it all together so that it makes sense. The electrical stimulus, which we call depolarization, is equal to systole, which is called contraction. The electrical repolarization is equal to diastole, which is the filling phase. I want you to understand that there has to be electrical activity before there could be a mechanical response. Simple as that. Let's move on and let's talk about the conduction. So you guys are pretty familiar with the conduction cycle. So the conduction cycle pretty much says that the SA node shoots off the electrical impulse, and the SA node shoots off its own impulses between the rate of 60 to 100. And that is actually the adult normal heart rate, 60 to 100. This electrical impulse travels down the interatrial nodal ways, okay, down the highways, and it goes to the AV node. The AV node is located at the bottom of the right atrium, and it actually can shoot off its own electrical impulses from 40 to 60. There at the AV node, we take a nice little break. We allow the ventricles to completely fill. We go down the little bundle of His. We hit the right bundle branch block, we hit the left bundle branch block, and that's when we have our ventricular contraction. The ventricles can also generate their own intrinsic rate from 40 to 60. Okay, so basically the pacemaker is the person who's responsible for sending out the electrical response. If it fails, decides it doesn't want to work, it's sick, it's been working too hard, it gives up, I don't want to do it, the AV node, which is the backup, it will come in at 40 to 60. I'm okay with 40 to 60. And if the backup to the backup decides it doesn't want to work, it will kick out its intrinsic rate of 20 to 60. Okay, so I wanted to put that out there so that you guys know that there are mechanisms, because the body is so wonderful and so dynamic, that are in place in case the SA node decides that it does not want to do its job, which is to be the pacemaker of the heart. Now, personally, I think this is the cool slide. This is the one I've been kind of wanting to talk about. So one side of this slide actually shows you what's going on mechanically, or actually electrically, and how it is represented on the EKG strip or the telemonitoring strip. so you can see. So where you can see at the top here, there is the SA node that is firing off its electrical impulse. And if you look over on the other side, it is represented by the P wave. And if you move down, you will see the AV node. And I told you there was a pause there at the AV node in the bundle of His, and that is represented by the PR interval. And that is where the conduction or the communication between atria and ventricles happen. There is a little delay there, and that delay allows for full ventricular filling. And then it goes down the right bundle branch block and the left bundle branch block and the right bundle branch and the left bundle branch, and gives you your contraction of your QRS. Okay, and that's represented there. And then there is a little relaxing there, and then the ventricles fill with your T wave. So I think this slide is pretty cool in letting you know exactly what is electrically going on and how it's represented in our waveforms with our PQRS T wave. Okay. So in order for us to cover one of our objectives, which was to identify waves, we need to talk about our waves. So here we're going to start off with the P wave. So the P wave is going to be the first positive deflection from the baseline. Okay, so when we think about the baseline, we're thinking about what we also call the isoelectric line. It is the straight line across the bottom that's starts at the beginning of the little diagram to the end of it. That red that comes off, that's going to be the P wave, nice and rounded. It comes before every QRS, and it is a representation of atrial contraction, the P wave. It says to me that the SA node fired off an electrical impulse. So I like this picture. It shows you how to measure. This is the PR interval. So the PR interval is actually representation of atrial contraction and to the beginning of ventricular contraction. So remember I told you there was that little break so that the ventricles can completely fill. This is pretty much what this is representing. And the time or the duration that it should be between 0.12 and 0.20. So this is the first thing that I'll tell you, the numbers that you'll have to remember when interpreting rhythms and looking at waveforms. It's the PR intervals. Sometimes you will see it represented as the PRI. Same thing, PR interval. And like I said, it is going to be that communication between atria and ventricle and how long it takes the electrical response or the electrical impulse to travel to the ventricles. I want you to try to remember that because you're old enough to think and make some decisions because you're 0.12, but you're not old enough to drink because you're not 0.21, you're 0.20. So that's the first thing that I want to pop into your head because it's the first interval that you have to come up with a number. Okay, don't think too hard about it. 0.120 to 0.20. Our next thing that we have to look at when we're understanding waveforms is going to be your QRS, okay? And your QRS is going to always be followed by the P wave. And this is actually ventricular contraction. And if you stop and think about it just for a second, the P wave was atrial contraction. It was smaller. It came up off of the isoelectric baseline, but it wasn't nearly as big as this QRS wave. That R wave is way at the top, and that's because those ventricles are big and they're thicker than the walls of the atrium. Another thing I want you to do is remember that we have to start measuring. The measurement is going to be at the beginning of the Q wave all the way to the end of the beginning of the S wave. And so its duration or its time is going to be less than 0.11 or less than 0.12. It just depends on the resource that you look at. But the catch is that we want it to be narrow. We don't want it to be a wide one. Now here's the thing. The QRS, or the ventricular contraction, it may look different in different patients, or even look different in the same patient, just depending on what lead we are using to look at it. Okay, so that's your QRS. And this one's a good one. Everybody usually can identify this one when they see it. So we're going to move on to the ST segment. So the ST segment usually follows the QRS complex, and it ends with the onset of the T wave. The ST segment basically represents ventricular contraction and the beginning, not the complete, but the beginning of the recovery of the ventricles. Okay, and sometimes we overlook it because the ventricles have done their thing, I'm good. But no, this is very important because we actually monitor this one to check for an indicator of myocardial infarctions or myocardial ischemia. So we look for either elevation or depression in the ST segment to find out what's going on with our patient as far as the oxygenation of the myocardium. So it's actually an important segment. And so if you look, it's flat on the isoelectric line. If it goes up or go down, then we start to think about if this patient has had an NI. T wave. So the T wave is sort of the last wave in the whole complex, sort of. Every now and then we end up with a U wave, and you know, that's a little bit different, but it represents the major portion of recovering, the ventricles recovering after depolarization. Remember, my brain works really crazy, so every now and then I'll say depolarization. That is contraction, guys, and I'll say repolarization. That's just relaxing. So just kind of follow me, and I try to make sure that I'm very clear when I am saying these things. So anything that interferes with normal ventricular relaxing may cause the T wave to become show some signs of ischemia. So I usually like to just say this is our vulnerable period. We like our ventricles to chill out, relax, fill up with blood, so that we can start our whole cycle over again. So basically, we've covered the major waveforms. We got your P wave, which is atrial contraction. We have your PR interval, which is that small delay between the atria and ventricles communicating. We have the QRS, which is ventricular contraction. We have the ST segment, which is the end of the contraction of the ventricles and the beginning of the recovery, and it is the place that we look at to see if the myocardium has decided that it didn't, get enough oxygen or anything. And then we have our T wave, which represents the ventricles relaxing and filling with blood. Okay, so now let's look at our QT interval. So we forget about the QT interval sometimes. Sometimes we don't pay attention to it, but the catch is the QT interval represents that complete period. It represents the total ventricular activity. And since ventricular activity is what gives us our cardiac output, I don't think we can overlook it. So just remember that it represents the beginning of ventricular contraction to the end of ventricular relaxing. And so we definitely have to remember that. And the wider it is, or what we like to use in this EKG world as prolonged, can lead to fatal dysrhythmia. So it is very important that we keep up with what the patient's QT interval is. So now, since we got that out of the way, let's look at how we look at this EKG paper and how we can determine what is going on, how to read this EKG paper. So here's your EKG paper. Obviously, it's going to be a long strip or a big box or whatever. And I want you to know that we have a horizontal axis and we have a vertical axis. Horizontal is across, vertical is up and down. So in the horizontal axis, we're going to look at time. Okay, so each little box is a certain amount of seconds. One little box represents 0.04, and it is important that you guys realize that I am saying 0.04 because that's a small amount of seconds, because that's not even 1 second. So 5 of those little boxes, which would be what I have represented here in this diagram, is going to be 0.20 seconds. And .20 should immediately pop in your head. Wait a minute. I remember somebody saying that the PR interval should be between 0.12 and 0.20. So if the PR interval is greater than 5 little boxes, then we know that it is what we call prolonged or wide. Okay, so prolonged is a word that we like to use. So there it is. When we look at our vertical axis, that is going to be, remember I was talking about the ST segment, and we looked at that for depression or elevation to decide if our patient has had some ischemia or an injury to the myocardium. So that is very important. We'll ask how many millimeters is it up or how many is it down to determine the degree of damage that has been done. So this will make a little bit more sense when we actually see our first rhythm, so you can look at these boxes. And as and I'm still clinically practicing, and those little boxes are there. There are lots of little cute little tools that we use to look at them. Okay. So once we get you get in front of a rhythm, and don't get all bent out of shape, because systematically, if you do the same thing every time, you will be able to determine if what the cardiac rhythm is. So the first thing you want to do is you want to determine if the rhythm is regular or irregular. And what I mean by regular or irregular is when you look at the R wave, which is represented there at the top, is it the same amount of distance from that R wave to the next R wave? So let's just say that between this R wave and the next R wave, there are 6 big boxes. And big boxes are the 5. The 4 little boxes, the 5 little boxes of 0.04. Okay, so let's say that. Then there should be that amount of boxes between each one of the R waves. I'm going to try to demonstrate that in a video a little bit later. See how talented I am. Okay, so we want to see if it's regular. So for everybody who's wondering what do I mean by that, I would like for you to, if you get an opportunity and you have a piece of paper with a rhythm on it, I want you to put the paper at the very top of your rhythm, and where you see the R, make a line, and where you see the next R, make a line, and you should be able to move those 2 lines up and down your strip or across your strip, and every time you place it on 2 R waves, it should be on those 2 R waves. If R waves come between those 2 lines that you made, that means that rhythm is not regular. The next thing you want to know is you want to identify what the heart rate is. What is the rate? Is the rate 70? Is the rate 40? Is the rate 78? 52? You want to determine what the heart rate is. How many beats per minute? And we should know this. We're beyond that stage. So that's the next thing in analyzing our rhythms. The next thing is you need to see, and that's why I put this waveform here. You need to make sure that there is a P wave, atrial contraction, before every QRS. Is there a P wave before every QRS? There's another part that actually goes to this. The P waves, do they look the same? Are they all rounded? Some of them kind of peaked and spiked. Are they inverted? Do they all look the same? And that's very important to know that. The next part in identifying is measuring the PR intervals. So remember I said measuring the PR interval, the duration should be 0.12 to 0.20. And I'm trying to make sure that you are able to take notes. And I did get some requests to email my PowerPoints, but I can't do that, guys. So I'm going to try to talk a little bit slower so you guys will be able to take notes and write all this good information down. So you want to measure your PR interval, because remember, if your PR interval is greater than 0.20, there is some kind of delay in the conduction or the communication between the atria and ventricles, and that just doesn't even sound right, okay? The next thing you want to do is you want to look at and evaluate your QRS complex. Do they look the same? Do they follow a P wave? Are they wide? Are they narrow? So you want to be able to really look at your QRS complex, okay? And remember with your QRS complex, they're supposed to be less than 0.11 or 0.12. So that is also important. The next thing I think that is important, and I don't want to throw this out, is looking at your relationship between your P and your QRS. And at this point, you can identify what your rhythm is, okay? Systematically, do it the same way every time, and it never fails. And I think that is very important for us to take. Okay, so now let me get in instructor mode. In instructor mode, guys, when we are giving you a test, we may have you measure out some of these things, so I did want to definitely put the numbers in there, but most of the time we want to know that do you know how this patient will look clinically, how this will, this patient is going to look. So I may throw some of that in there so that you guys can start thinking right. All right, so let's try to determine some rhythms, and let's try to look at what heart rates are. So the most common method that we use is called the 6-second method, okay? So we're going to start with the bottom picture because it represents the two sections of a 3-second strip. So you have the first section is 3 seconds and the second part is 3 seconds. So together the bottom strip is a 6-second strip. Give you a minute to look at it. Remember, I told you each of those boxes, so those are going to be the bigger boxes, represent 0.20. 30 of those boxes are going to be a 6-second strip. No, we do not count them. There are little hash marks at the top, guys. And the little hash marks at the top is what helps us to know if we have a 6-second strip or not. So just remember that. So if you can see at the top, they actually counted them out. You make sure you only count the QRS complexes that are in between the hash marks, okay? And I'll point them out in the next strip when we come across them. So today we're going to discuss sinus rhythms. When I say a rhythm is sinus, that means it has a P wave. It came from the sinoatrial node, the electrical impulse. Normal sinus rhythms, sinus bradycardia, and sinus tachycardia. So let's talk about sinus rhythms. So our first rhythm that we're going to discuss is going to be normal sinus rhythm. We say that it is normal because it has a regular rhythm. The rate is between 60 and 100. There is definitely a P wave before every QRS wave, and they all look alike. The PR interval is in a normal range of 0.12 to 0.20, and it is constant. And the QRS duration is less than 0.12. That is normal sinus rhythm. Everything is at its normal baseline. This is what normal sinus rhythm looks like. You can see the hash marks actually on this one. If you look at the top, this is actually a 6-second strip. When you count the QRSs, you're not going to count the last one on the strip because it is outside of the hash mark. So if you actually count them, there is 1, 2, 3, 4, 5, 6, 7, 8. There are 8 QRS, and so we will multiply that by 10, and we will get that the heart rate is 80. So that's kind of how that is done. Although we use the 6-second strip as our, we use this one more commonly. It is the least accurate one. Okay, so I definitely wanted to let you know that. But this is the one that we can very quickly eyeball and not have to do a whole bunch of math to look at. Let's look at sinus brady. Sinus bradycardia. Sinus bradycardia is pretty much going to follow everything that normal sinus rhythm did. The catch is the patient is going to be bradycardic. So because we are at rhythms, I know you know what bradycardia is, and bradycardia is a heart rate that is less than 60. Okay, so the rate is going to be less than 60, but the rhythm is still going to be regular. The P waves are still going to be upright and before every QRS. The PR interval is still going to be in its normal range and constant, and the QRS is still going to be less than 0.11. Okay, so this is the part that, isn't all that fun, but we still have to kind of cover it because when we start getting to the more complicated rhythms, I need you to understand that. Yes, and this is how sinus bradycardia looks. I'm going to give you guys a chance to look at it, but I want to say this first. This is a 6-second strip. So with that being said, um, and we normally sometimes when we print them out, they come out in the 6-second strips, and we'll know that. Sometimes you actually have to, do a little extra digging. Like I said, it's 30 boxes. Um, the hash marks are not so much. You can do the math though. The hash marks are a little bit different on here. So I'm going to give you a second to look at this strip and see if you can determine what the heart rate is. Absolutely, this heart rate is 40. So, like I said, even though it sometimes is not the actual heart rate, this heart rate could be 42. This heart rate could be 38. Either way, I don't like it. so there we go. A lot of things could cause this, beta blockers, ischemia. It could be normal for athletes or drugs or something like that. So this is your bradycardic patient. Let's move on to sinus tachycardia. So same thing, guys. The only difference here is the patient has a heart rate that is greater than 100. That heart rate can go all the way up. I'm talking about to numbers like 150, 160, 170. So, keep that in mind. The higher the number goes, we want to start calling it all kind of other goofy names. We could have gone over rhythms for the rest of this week. So I wanted to let you know that the thing that I want you to pay attention to with this one is, yes, it is still going to be regular. There is still going to be a P wave before every QRS, and it's going to look alike. The catch is that the P wave, because our heart rate is so fast, they are starting to get closer and closer and closer to the T wave. So at a rate of about 160, a rate of about 130, you can't really distinguish the P wave from the T wave. Hear me out. The heart rate's so fast that you can't distinguish the P wave from the T wave. They start to almost merge together the faster the heart rate is. So it is very important that we look at the QRS to see if it is narrow or not, to find out if this tachycardia is above the ventricles or below the ventricles. Or erase that, because that may be a little too complicated at this stage. But we'll talk about it when I talk about rhythms in critical care. So here we go. Here's an example of sinus tachycardia, and like you can see, the P waves are actually identified for you, but look how close they are to the T waves. All right. Okay, so do me a favor, guys. Take a minute, count them up, tell me what you came up with. You should have came up with 110. Should have come up with 110. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Yes, there are 11 on there. You're going to count every QRS on there because that is a 6-second strip as well. And the one thing I want you to think about before we even get on to video 2, talking about treating these, is that if the heart rate, if the P wave is coming so quick, it's not giving the ventricles a full time to fill with the blood. And if we're not getting full ventricular filling, we're going to have a decrease in cardiac output. Not a good thing. A lot of stuff can cause this as well: pain, fever, exercise stimulants. So think about that kind of stuff. Those are your sinus rhythms, guys. You have normal sinus rhythm, you have sinus bradycardia, you have sinus tachycardia. So you have normal, slow, and fast. Okay? So now we have to go one step further, put your big girl, big guy hat on, and talk about atrial rhythms. So we're going to talk about atrial fibrillation, we're going to talk about premature atrial contractions, and we're going to talk about atrial flutter. So I'm sure you guys have been all waiting on talking about atrial fibrillation. I know I have. Atrial fibrillation, it is the most common dysrhythmia out there. Yes. So let's talk about it. Let's go on. Lots of stuff can cause it. Basically, what's going on is that atrial activity is all jacked up. Yep, I put it out there. Sorry, my way of saying it. So you have no identifiable P waves because the atria is not contracting. It's not squeezing. It is actually shaking. Shaky, shaky, shaky. So basically what we'll say is there are multiple ectopic foci that are trying to shoot off electrical activity. Unfortunately, this results in a loss of atrial kick and an ineffective atrial contraction. So every now and then, maybe, want to get through and we're like, oh, there goes atrial contraction. But for the most part, we just don't have that. When I keep talking about this atrial kick thing, I'm talking about that extra, you guys know that the blood actually does pass down to the ventricles passively. And then there is that atrial contraction, and that's the atrial kick that you get, and that's about 30% of cardiac output that we want to actually go into the ventricles to give us that cardiac output. Anyway, this increases with age. Okay, so that atrial rate is going to be faster, and we're not going to even know what it is. That's how fast it's going to be, than the ventricular rate. It's just shaking. Okay, and the bad thing about that is anytime that the ventricles or any of those chambers, including the atria, are not completely contracting, the blood is pooling in there. So anytime blood pools, yep, you got it, clots. So this is how it looks. You know, and I'm not sure if I said it on the last slide, but it's not a regular rhythm. So as you can see that some of them are closer together, some of them are further apart. They're not all consistent across the state. So that's one of the things when you're looking at a rhythm and you say, I'm not 100% sure if I see P waves or not. When you look at it and you say, no, that's not regular, because the first two are kind of close, and then the third one is really far from the second one, and then the next three are kind of close, and then the sixth one is kind of far. Yeah, okay, so no, that's not a regular rhythm. You can't identify a P wave or a T wave or any of that. That is your classic rhythm that is atrial fibrillation. And you actually can count the QRS complexes to see what the rate is. Like I said, lots of things can cause this: CAD, coronary artery disease, cardiomyopathy, heart failure. So that is your atrial fibrillation. The next thing we're going to talk about is premature atrial contraction. So this one's kind of tricky, guys, and I try to explain this the best way that I can so the students can get it. With premature atrial contraction, basically you have an early beat, an early sinus beat. And if you're not paying attention, you may miss it because the complex looks just like all the rest of the complexes. So what ends up happening is your heart's beating, bump, 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 bump. So it's just a little extra beat thrown in there. Whoop, slip one in. Gotcha. So if you don't pay attention, you can actually miss this. When it slips one in on you, it kind of has to pause a little bit just so it can get itself back together. Because, oops, one slid in, now let's get back on track. So that's what I mean when I say a non-compensatory pause that comes afterward, okay? So I will show you how that looks. There we go. So this is your premature atrial contraction. So if you look at them, all of them look really good. If I didn't have them identified, you probably wouldn't even know that they were there. You would actually have to measure them out so that you can actually see this. So, you know, that's the thing that I kind of wanted to show you. That if you're not careful, you can miss a premature atrial contraction. If it's not a lot of them, we really don't bother them. If the patient wasn't on the monitor, we probably wouldn't even know they were going on. If there's a lot, obviously the patient will probably be complaining of palpitations. Atrial flutter. So atrial flutter, I always think is kind of like AFib's cousin. So same thing is going on. You have, instead of having a wavy baseline, you have a fluttery baseline, or what we say sawtooth baseline, and or better to understand it would be a jagged edge kind of thing. And it actually originates because of a single ectopic foci issue there. So it's not completely all irritated like in there. And you can actually count them. Let's kind of look at a flutter one. So here we are. You can actually see where the QRS is. And I just want to point this out, guys, because I didn't even realize this when I was putting this together. This is in a different lead that I've been showing you. I've been pretty much showing you everything in lead 2 where all of the all the waves go up. If you look at the QRS one here, they actually go down. And the flutter waves are actually identified for you. So if you think about sawtooth, flutter waves, jagged edges, whatever you want to call them. And normally this one is going to be a regular one. So like I told you that AFib is not regular. This one is pretty regular. So you can actually count 4 flutter waves to a QRS. Okay. Now, this is where things get weird. And don't get mad at me, but I had to throw them in here because everybody needs to know about a block. And as an instructor teaching in critical care courses, I always want to put on a first degree AV block or a complete third degree AV block. It is my thing. I'm going to do it. So we're going to talk about atrioventricular blocks. Okay, the first degree AV block, the second degree AV block, and to confuse nursing, we put two of them in there. So there's two types. And then there is the third degree AV block, which is also called the complete heart block. So, I like to get layman's terms on you guys. Heart blocks. There is a delay in the conduction from the impulse of the atria and the ventricles. Okay. So here's my little story. The atria and the ventricles are married. They're friends. They're the best. The husband, wife love you. I don't know who's the man, who's the wife, but whatever. They love each other. They march together. Bump, 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 bump. One's not seen without the other. They're together all the time. They hold hands. They're friends. So if stuff starts going wrong in a relationship, they seem to grow apart, just like with any relationship when there starts to have problems. So we figure out what's going on with these problems depending on the location. Is it the AV junction? Is it a bundle of hairs? Is it a bunch of branches? And all of this is identified by the length of the PR interval. Okay, if that makes sense to you. So that's why I kept making a really big deal about identifying what the duration was for the PR interval. And I said, you're old enough to think, but not old enough to drink, because I know that we know you have to be 21 to drink. And so if you know that it's 0.12 to 0.20, then you can remember that, because the first degree AV block is identified with a PR interval that is greater than 0.20. And the good thing about the first degree AV block is that all sinus impulses make it to the ventricles. All the electrical impulses sent by the SA node make it down to the ventricles. The thing about the second degree AV block, Mobitz 1 and Mobitz 2, is some of the sinus impulses reach the ventricles, but some of them don't. Think about that. Yeah, now think about it. Now the SA node, who's the pacemaker of the heart, I run this. I make stuff happen. Some of them make it down to the ventricles, and some of them don't. Now the catch about that is that in order for us to have cardiac output, the ventricles have to contract. Just period, point blank. There's no other way around it. So if there are impulses that are not making it down to the ventricles, so the ventricles can contract, we're in trouble. What are we going to do? Okay, right. So now let's think about the third degree block. The third degree, which is the complete heart block, that just lets you know it's a complete heart block. There is no communication between atria and ventricles. They have gotten divorced. Everybody is mad. People are moving on. People are doing their own thing. You didn't see it in the real world. It's going on. Third degree, no sinus impulses reach the ventricles. All right, let's move on so you can see it. Maybe we can move on so you can see it. Okay, so here we go with the first degree AV block. This one's the easy one. Every impulse is conducted to the ventricles, but the duration to the conduction is a little bit prolonged. So the PR interval is going to be greater than 0.20. The electrical impulse is going down there and it's taking a little bit longer to get to the ventricles. Remember I told you there was a delay at the AV node anyway? Okay, now it's a real delay, like a little bit longer. Okay, and so lots of things can cause this. That delay is consistent from complex to complex. So if the PR interval in the first complex is 0.24, then you can pretty much know that all of them are going to be 0.24. That is what it is. And that's the first degree AV block. Patients have them, and we sometimes don't even worry about them. Okay, so I do have to say this as an instructor teaching at a pre-licensure college and teaching students the basics. I really try desperately hard not to confuse you with with second degree, type 1 and type 2. I am going to tell you about them because I do not want you running around here thinking like a nurse and being left outdoors on my blocks. But I do not want you to rack your brains trying to get a full understanding. You will not be a cardiologist after this. if you go to a telefloor, you will get more training. But I'm going to throw it out here for you and try not to spend too much time on it, because normally if we test type 1 or the third one. Okay, so here, with type, the second degree type 1, the PR interval, and that, then you just look at it, okay, it's the third one on there. The PR interval is growing longer and longer with each QRS. So the PR interval could start off at 0.22, and then in the next complex, the PR interval could be 0.24. And then in the next complex, the PR interval could be 0.28. And then in the next interval, the PR interval could be 0.32. And then there could be no P wave. And as you can see, no QRS, I'm sorry. And then as you can see, look, we didn't dropped off a QRS right there. Oh, yeah. Okay. So longer drop. That is called the Winky Bach. So that is what the second degree type 1 Winky Bach is called. And like I said, at a beginning nursing level, you will not be required to know that. What I will say is that for your second degree type 2, the PR interval is fixed. Okay, the PR interval, basically you can march them out. They're regular. So if you go from one P to the next, that's the same. You could move it all the way across. But occasionally there's just not a QRS. That's messed up, ain't it? Okay. And then your third degree heart block. This one is, like I said, let me go back to this screen. Like I said, the ventricles are doing their own thing. The atria are doing their own thing. And here's the thing about that. When I say the atria is doing its own thing, SA node is firing off stuff. Hey, I do my thing at 60 to 100. Bloop, 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 bloop. Heart rate, heart rate, heart rate, heart rate. And ventricles is like, she over there doing her own thing. I'm doing my own thing over here. I do my own thing over here at about 20 to 40. Yeah, bloop, bloop, bloop. They are not associated with each other at all. So remember, when you look at your third degree heart block, you're going to always see more P waves, because as SA node throwing out its inherent rate of 60 to 100. Bloop, 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 bloop. And the ventricles are doing their own thing. There's no association. There's nothing going through. And I mean, the sad thing about it is we really can't, a patient can't live like this. We have to get them a pacemaker. And so that's pretty much what's going on with there. There is no connection between each other. Everybody is operating what we call independent. They have gotten a divorce. And this is pretty much what's going on here. You see lots of P waves and not so many QRS. Remember, our cardiac output comes from QRS, from ventricular contraction. Hope that all made sense. Okay, cool. Let's move on, guys. Ventricular dysrhythmias, of course. We're going to talk about those. They have to be out here. We have to be able to identify them. We have the premature ventricular contraction, which we call PVCs. And we have ventricular tachycardia, which we call VTAC. And we have ventricular fibrillation, which we call VFib. Okay, so let's talk about them. Well, I see I started pretty ballsy here. So with ventricular tachycardia, this is actually considered a life-threatening dysrhythmia because of the decrease in cardiac output. What you have on here is a rate that's really fast. It is regular, though. Yeah, imagine that. Yeah, but you can't see any P waves. There's no PR interval. If there's no P waves, obviously there's no PR interval to look at. And the QRS, look at that. It is greater than 0.12. So that's a little bit different than what we had kind of been talking about as well. This is a larger PR interval. So this is nice and wide. And remember I said we like them to that QRS to be narrow. Okay, so let's look exactly at ventricular tachycardia and how it looks. You're absolutely right. It is regular. Okay. So this is repetitive firing of the ventricles. The bad thing about it is the ventricles are pissed off. They're irritable, and that's why they're doing that. And when we talk on our next video about how we can identify what to do, there's two things I want you to think about. Does this patient have a pulse or not? Okay, cool. Now we're gonna slide down to a little bit more calmer beat. We have premature ventricular contractions, what we call PVCs. And you'll hear people say, oh, my patient had 5 or 6 PVCs. Okay, cool. So this is a result of irritability of the ventricles, okay, as well. So, but we still have regular complexes. If you look, there is a regular complex. There's a goofy looking, wide and bizarre looking thing. And you're like, wait a minute, Shamel, we ain't talk about that. Exactly, that's a PVC. And then there are 2 more regular complexes. So if you look at those regular complexes, they have P waves, they have QRS, they have T wave. Everything is looking good, but then you got some goofy little thing in there, and that is a PVC. It is a early ventricular complex, followed by a pause. If you look, there is a little pause before we get to the 3rd beat. Okay, and for the record, there is no the PVC is not giving you the cardiac output, okay? So it's not a what we want to call a real beat. It's actually a warning that we need to check and assess our patient and assess some things about our patient. And like I said, when we talk about treatment and management of this patient, we'll talk a little bit more about that. Ventricular fibrillation. So basically what's going on here is we have chaotic, retarded, rapid electrical activity just all over the place. We don't know if it's regular or if it's not regular. There is no pattern to look at. You can't see a rate. There's no P's. There's no PR interval. There's not even a QRS. Now that scares me. There's no QRS because we know that QRS represents what? You're absolutely right. Ventricular contraction. So if there's no ventricular contraction, then there's no what? You said it. Yeah, don't come on, get your confidence up. There is no cardiac output. We need to have QRS. They are important. So at this time, this is a life-threatening dysrhythmia. We have to, as nurses, be able to identify this and know exactly what to do. Let's look at it and see how it looks. Yep, looks like your little kid trying to write in cursive. Exactly. The catch is there is electrical activity, and we need to move really quick before there is no electrical activity. So that's the thing right there that we have to have serious dysrhythmias that are going on there. There is no contraction. There is no cardiac output. The patient is unresponsive. The patient is pulsing. The patient is apneic. The patient is dead, basically. And it is up to you to be able to identify this rhythm. So at the level that we are at, about to become registered nurses or even licensed LPN, we need to know what to do when we see this rhythm. We need to know what to do when we see VTAC. We need to know what to monitor when our patient is in has a 1st degree AV block. We need to know what the anticipate what the doctor's going to be ordering if our patient converts to atrial fibrillation. Atrial fibrillation. We need to know what to prepare our patient for if they're in a complete heart block. Those are the things that I kind of want you to start thinking about. So I want you to be able to identify what is going on with your patient and how to manage it. I wanted this video to pretty much be so that you will understand how to look at the rhythms, how to identify the waves, what's going on mechanically with the waves, what's going on electrically with the waves, and then the next video we're going to put out is going to be how do we clinically manage the patients. As long as you remember how to analyze your rhythm, you're going to always come up with the right thing. You want to make sure the rhythm is regular or irregular. Identify that. You want to look at the rate. You want to analyze, is there a P wave before every QRS wave, and do they all look alike? You want to measure your PR interval, and you want to make sure that your PR interval is constant. You want to look at your QRS and see if what the duration of your QRS is. You want to make sure that you are doing this the same way all the time. Okay, as long as you do these things, guys, you will be able to analyze your rhythm strip and move on from there. Remember the blocks. I don't want you to stress yourself out about the blocks, but this is pretty much what it is. Please make sure that you subscribe to the channel. We're going to be trying to put videos up every week. Tell me what you like. Tell me what you don't like. Tell me what you'd like for me to do different. I am definitely trying to help you guys out in the best way that I can. And I will see you next time.